OrthoTV online in association with Pulse Pharmaceuticals, the makers of Bakbone and Deksel. To introduce today's topic and the speakers, I hand over to Dr. Akash Saraogi.
Thank you very much, Dr. Bijlani, and my special thanks for giving us an opportunity to host this program, this series, time and again. And the kind of response that we have been getting, it only goes on to motivate us to have more and more such debates. I'm Dr. Akash Saraogi. I look after medical affairs and clinical research of Pulse Pharmaceuticals, extending you a warm welcome on behalf of the organization and also OrthoTV. Ladies and gentlemen, this is, as you are aware, this is the fourth program in the series. And consistently, we have been debating on the relevance of FRAX tool in the assessment of fracture risk and how it can be more relevant. And today we have speakers who can share much more light on that, and especially Dr. Saraogi has some thoughts which he will be sharing during the course of the program. But before we go on to this academic part, I would like to briefly introduce my organization, which is Pulse Pharmaceuticals. We are a Hyderabad-based company, and I hope my slides are visible. As I said, to begin with, today's Tete program is between Dr. Akash Saraogi from Mumbai and Dr. Buddhadeb Chatterjee from Calcutta. Dr. Buddhadeb Chatterjee or Dr. Saraogi, I'm sure, need no introduction to the audience, but it's customary, so I'll be reading out a few lines about them, which I've been able to pick from somewhere on the internet. Dr. Chatterjee has been formerly associated with Bahrain Specialist Hospital and Apollo Hospital at Bilaspur. Today, he's a director of Apollo Multi-Speciality Hospitals at Calcutta. He conducts arthroplasty workshops and AO trauma courses in India and Southeast Asia. He's a pioneer in unicondylar knee replacement surgery. He has published on behavior of osteochondral grafts, and his area of special interest is joint replacement surgery, ACL reconstruction, knee braces for osteoarthritis, knee replacement, and minimally invasive knee correction. With these words, I welcome Dr. Chatterjee to this Tete program. And we also have the pleasure of having a very young and dynamic orthopedic surgeon in Dr. Akash Saraogi, who is a managing director and consultant and head of Saraogi Orthopaedic Institute at Malad, Mumbai. Dr. Saraogi has been a gold medalist throughout his academic career. That's what I realized when I was going through his internet profile. He has been a recipient of Sir Walter Mercer Medal, Sir John Shanley Gold Medal, Padma Bhushan, Dr. K.H. Sancheti Gold Medal, and Dr. Dayanand Dongaonkar Gold Medal. He has also been a recipient of Sir John Charley Award for Best Paper in 2017. He has received his trainings and various certifications at Edge Hill University, UK, and Brighton Hospital, UK, Psychot, Italy, and Hospital Infanta Leonor at Spain. One thing I would like to make a special mention is he has been actively involved in treating patients who do not afford treatment with his association at the state-run Sir J.J. Hospital, which is the associate hospital of Government Grant Medical College at Mumbai. And he is also associated with this college as in the capacity of an associate professor. With these words, I extend a very warm welcome to Dr. Saraogi also to this Tete program. But before we go on, one last thing is my duty to do. I would briefly like to introduce Pulse Pharmaceuticals to you, ladies and gentlemen. We are a patient-centric, innovation-driven, integrated pharmaceutical company with inclusive growth model. We have our manufacturing facilities, we have our raw material manufacturing facilities, and also we have the R&D setups. And we have been in existence for 25 years. This is our silver jubilee year. We are present across India and in emerging markets. We are making forays in the European Union. We also have plans and we are working towards getting our presence in the US markets. We have world-class R&D and manufacturing facility and infrastructure. A huge part of our R&D is devoted to developing nanopharmaceuticals. And I'm sure many of you would be aware of Deksel, which is coming out from the stable of the Pharmaceuticals. We have a strong leadership and operational team across all business functions. We have 7 divisions operating or catering to the various specialties. But the principal focus is the orthopedics and the neuropsychiatry. We are leading in the space of nanopharmaceuticals and the drug receptor research. There are many nano formulations which are in the pipeline. Some are already there in the market like Deksel and Melsoma and Densium ND3 as well. We have a strong presence in medical nutrition through Pulse NutriSciences. We have a manufacturing facility for these medical nutrition therapies at a place called Shyam, close to Hyderabad, so where we make diabetic food or food for nutrition for patients undergoing the dialysis, patients with CKD, and so on and so forth. And of late, we are tied up with the Center for Cellular and Molecular Biology at Hyderabad, where we are working on stem cell therapies, the CAR-T technologies, where we are using our expertise in the recombinant DNA technology, and we are trying to bring in more of personalized medicine. With these words, I thank you for joining us, and I hand over the academic session to Dr. Akash Saraogi for his deliberations on the continued relevance of FRAX. Before Dr. Saraogi starts sharing his thoughts on that, I would also like to inform or say that yes, we look forward to understanding that how well the FRAX tool is adaptable to the Indian situation, particularly looking at the socioeconomic demography of the country. There have been thoughts about combining FRAX with Dexa. I would like to have your thoughts on that too. Also, we understand that it talks about the risk assessment over the next 10 years. But it cannot be used for evaluating what is happening with the current interventions. So is there a need for a modification? It also does not take into account per se the usage or supplementation of vitamin D in the near future or in the past, which has happened. Also, somewhere there are emerging risk factors for osteoporosis like homocysteine. There are factors like iron deficiency anemia is also coming along very strongly. So these are the various things that we would like to hear from you and understand from you. With these words, I stop my presentation here, and I invite Dr. Akash Saraogi to share his thoughts on the continued relevance of FRAX. So over to you, Dr. Saraogi.
Thank you so much, sir, for this kind introduction. I'm just going to share my desktop. Okay, are you able to see my screen?
Yes, your screen is visible, sir. Go ahead, please.
So thank you so much, OrthoTV and Pulse Pharma, for this opportunity. I feel very obliged and thankful to be sharing this virtual dais with Buddhadeb, sir. And I hope that I'm able to make some difference at the end of this presentation. To give you a brief description about myself, so I've done my MBBS from Nair Hospital in Mumbai and PG MS from JJ Hospital. And after doing my PG, I did work as an assistant professor full-time at JJ Hospital, after which I went on to UK at Wrightington Hospital. I'm sure most of my orthopedic friends would be aware of this place where Sir John Chanley worked himself. And after completing my MCH and FRCS, I moved back to Mumbai in the year 2018. And I am presently working at Sir H.N. Relevance and Nanavati Hospital. Today, I'm going to talk about an overview of osteoporosis and the relevance of FRAX in the Indian scenario. And I would really welcome if any inputs from Buddhadeb sir while I'm presenting. So as you are all aware, osteoporosis is not a problem of quality of the bone, but it is the problem of quantity of the bone, which means that per unit area of the bone, the amount of material that you need is deficient. What are the symptoms? None. Practically, we have no symptoms of osteoporosis unless the patient lands up in our clinic with a fracture. So even if the T-score is more than -2.5, it is on the very lower side, the patient may still not present with any symptoms and may directly present to us either with a vertebral fracture or a hip fracture like this. We all know about the changes in bone density with the age, and we know that it increases with adolescence, moves on to have a peak bone mass by the time we reach around the age of 30. And then the plateau is maintained for some time. And when we get age-related bone loss, about 0.5 to 1% per year. It accelerates with menopause, goes up to 1 to 2%, and then age-related bone loss resumes to the same level. We all know that the cortical bone and the cancellous bone, they behave differently. The cancellous bone has a steeper fall of bone mass as compared to the cortical bone. And that is the reason why we are looking at wrist fractures, followed by spine fractures, followed by hip fractures. This is the overall osteoporosis. We don't need to get into the details of this. All we need to know are the factors that are responsible, one being age, the other being the hormones. Then there are some clinical risk factors and very high bone turnover in some individuals, which will lead to osteoporosis. This is the projected worldwide increase in hip fracture number. Of course, we have increased longevity of life and we have increased osteoporosis. So the problem with osteoporosis is only increasing. The problem with hip fractures is only increasing. We have two different types of falls, one with the younger patients, the one with the older patients. Younger patients have intact protective mechanisms, so they tend to fall on their hand and they have peripheral fractures. Whereas older patients have more compromised protective mechanisms. They can fall on side or they can fall off straight and they land up more commonly with a hip fracture. With regards to vertebral fracture, if you see in the curve, you can see that the incidence is much higher in women as compared to men. And there's a steady increase by the time we hit the age of 80. Similarly, there's the most common osteoporotic fracture. And what is the importance of vertebral fracture in clinical practice? Your vertebral fracture is a marker that this patient is going to have another fracture in the future. So vertebral fracture is a marker for future fracture risk. And this is the most important takeaway from this talk today. Many of these vertebral fracture may not be with a significant fall. They may be with some everyday activity like lifting, pushing, pulling, etc. Only 25% to 30% of vertebral fractures seen on X-ray are diagnosed clinically, which means that many of these are non-clinically existent, where the patient has not presented to you, but they exist. With regards to hip fractures, of course, they are more dramatic, again, more in women as compared to men, and a steeper rise of curve, as you can see in incidence. Distal forearm, distal radius fractures, of course, again, you can see the curve, which is very similar to the other fractures. So one important thing is survival rates. We all need to know that these patients who present to us with hip fractures, they even have reduced life expectancy. And you can see the percentage survival in this graph, which over a period of years, survival seems to decrease. Fractures don't only reduce the quantity of life, but they also reduce the life quality of the patient. And you can see how many patients may end up in a nursing home in a Western country or are bedbound at home in India. And that is what affects their quality of life. We all know about the WHO classification for osteoporosis, post-menopausal one. And I don't need to discuss this. We all know it's -2.5, more than 2, equal to or more than 2.5, which signifies as severe osteoporosis. Dexa scan is what we use to quantify osteoporosis in our clinical practice. We all have looked at this scan, which shows a lumbar vertebrae between L1 to L4 and the proximal femur, where we are measuring the scan in the femoral neck. In the forearm, we looked at the distal radius and the forearm. So why do we use a dual energy? when it comes to osteoporosis Dexa scan, because we have bone as well as soft tissue. The density of the bone and the soft tissue are very different. So the energy absorption is very different. If we don't use dual energies, the Dexa result in a fat patient and a thin patient will be very different. So as to have a standardized result and take away the confounding factor of fatness or the tissue, we have dual energies, because bone attenuation will be greater than soft tissue. And with a higher energy, the bone attenuation will be similar to the soft tissue. So we are able to differentiate and we can remove that soft tissue component completely because we have dual energies. So I have already told you this, that it eliminates the need for uniform object thickness, and it partially corrects for presence of varying amount of fat over the bone. And this is a component of the typical Dexa scanner. This is just to give you a screenshot of what exactly do we do in a Dexa scan. So when we talk about the components of the BMD Dexa, it is said that spine is probably not a very good site to diagnose, but it is a very good site to monitor the response. This is what the review of literature says. You may have patients with different degrees of degenerative changes in the spine, and the BMD with a sclerosed bone may be spuriously may not show you as much osteoporosis because the bone is sclerosed and it has not been picked up well by the scanner. So hip is probably a better site than spine when you come to diagnose osteoporosis. In terms of monitoring response, definitely spine is a much better site to show you what response you have had after you have treated your patient with osteoporosis. Some people use one over the other. There is immense literature to suggest. Definitely, Chatterjee sir might be able to tell us what he uses in a clinical practice. I sometimes use combination of two and whichever is lower. USG, yes sir.
Yeah, I think the Dexa is a very important investigation. It has to be done in all patients. What is perhaps a bit of a controversy in the United States, you see every woman above 65 is subjected to a Dexa. That's not the case in Europe and also in India. So I don't know, that is arguable, I suppose, because as you said, this is a silent disease, and unless you actually are very proactive in doing a Dexa, you will not be able to diagnose it. So, of course, the Dexa is required. And apart from that, I do a lot of other things. That is the vitamin D, the PTH, the alkaline phosphatase is also, I think, needs to be done because they are important determinants of subsequent treatment.
Thank you, sir. So another important thing to point out is many of you must have seen those USG-based USG-based BMD machines. And those are absolutely not recommended for quantifying the osteoporosis. They can be highly misleading. So when you talk about osteoporosis and bone mineral density, it has to be Dexa. One important topic that I want to introduce before I actually talk about FRAX is the relevance of trabecular bone score. And not many of us orthopedic surgeons know about the trabecular bone score that well. So what is trabecular bone score? It is basically a Dexa software program that estimates the bone texture from a regular PA spine Dexa scan. Now I'll just tell you an example what it exactly means. If you look at the screen, you can see that there are some white areas over here, there are some gray areas, and there are some dark gray areas, right? And it is homogeneously different. You can have uniform dispersion of white, gray, and dark gray areas. Whereas if you look this heterogeneous bone structure, you will have one area which has got too many white structure and one area which have got too many dark structures, which means that the above bone is homogeneously deficient. The holes, if you see in this microarchitecture of the bone, they are uniformly distributed. Whereas if you see this lower one, if this bone that you see, at some areas the bone structure is quite robust, but in between you have those areas which are very big stress risers. And this is what is the concept of trabecular bone score, which means that a heterogeneous trabecular bone score or heterogeneous bone structure is at much higher chance of a fracture as compared to a homogeneous bone structure. Now, mind it that both of these bones have got absolutely the same T-score on the BMD scan. There is no, even this is minus 2.5, and even the lower one is minus 2.5. The difference is in the distribution of good and bad areas, whether it is uniformly distributed or badly distributed. So this is one thing which we need to consider in our patients. So a higher TBS correlates with a better bone structure, a lower TBS correlates with a worse bone microstructure. And a lower TBS is definitely at a higher risk of a fracture as compared to a higher TBS with the same T-score on the BMD scan. So this is another take home from this talk today, where I wanted to look at the trabecular bone score and you can ask for it. There is also an adjustment that can be done in the FRAX, which we are going to talk about now, with regards to the trabecular bone score. So if you put on the value, this is a screenshot of the Sheffield site, which I use in my clinic as of now, which is for the trabecular bone score. And if you put the trabecular bone score over there, you will come to know that with the same BMD, the person who has low TBS will be at a much higher risk of a fracture as compared to a person with a higher TBS. So this is how you enter the score, and this is how they will give you the 10-year probability of fracture. So coming to the FRAX tool, it was first passed or used by WHO on 21st of February 2008. And what it does is it gives you a rough estimate of a 10-year probability of you having a fracture. Now, how does it does that, and why 10 years? And how do they come to this conclusion that this is going to happen? This is like you're trying to tell the future. So it is nothing rocket science, but about 30,000 odd patients data was collected, and this data was analyzed, compared to their demographic characters with that region, with the number of fractures that the patient had, their BMD scans, and all those things were collaborated and seen that how many really had a fracture over a period of 10 years. And they went 10 years back and saw all those factors which were responsible and came up with the conclusion that these are the criteria which are important, and they will suggest whether the patient is going to have a fracture. So this is the most important slide, where three main variables of the FRAX tool are discussed. One is the BMD, which we all talk about. The other is the BMI of the patient. The third is the age of the patient. These are the three main variables on which the FRAX tool assessment is based. The BMD is very specific, but it is far less sensitive as we can think. The various risk factors which are associated with fractures originally given by the FRAX tool are these. This is the BMI of the patient, if the patient had a prior fracture or not, especially a vertebral fracture, if any of the parents of the person had any hip fracture, if the patient is an active smoker, if there is history of past or present steroids, if there is alcohol intake of more than 2 units per day, if there is rheumatoid arthritis, and of course the age. For women, the age was set at more than 65. For men, it was set at more than 75, because women have faster rate of osteoporosis considering the hormonal changes. And this was the link for the tool. And if you click on the link, you can directly go to that tool. So it gives you a approximate gradient of, what exactly happens, what is the chance of a hip fracture, what is the chance of other fractures. With each of the variant you can have, and it will give you final score of what is the chance or what is the percentage probability of someone having a fracture in the next 10 years. This is what a FRAX tool is about, and these all variables were originally there. Now we need to remember that not all the variables have been covered in this. Over a period of time, we have realized that there are so many other variables which can cause or lead to a fracture in an individual. But these were the most common ones which were found in those set of patients in those particular European countries. And that is the reason this was used. Definitely, there is an advantage of FRAX that many times BMD may be a little bit misleading, and you may overtreat your patient. You may have younger women with low T scores, but a very good FRAX assessment. and she may not be predisposed to fracture, and you may end up over-treating this woman. So FRAX gives you a more realistic clinical picture of how the patient's bones are, whereas a BMD Dexa will give you more theoretical kind of thing where clinically the patient may not be relevant. Monitoring is easy. So using the FRAX tool, definitely monitoring is a bit more easy, and you want to definitely modify those modifiable factors and give an objective assessment to the patient that, see, objectively, this is what the difference is over a period of time. The clinical severity can also be judged with the help of a FRAX tool. Of course, there are some limitations with FRAX, especially there is an option in the FRAX tool where you could do the FRAX tool without the BMD. Now, this is a matter of debate, because you might say that in rural India, where 70% of the population still lies, there may not be a Dexa scanner. So how do you know the BMD of the patient? So there is FRAX tool available to do the FRAX assessment without the use of BMD. So, I mean, the tool itself can guide us whether in this particular patient, how important it is to do the BMD. That's number one. It may not always guide the treatment as compared to just doing if you have not done the BMD, it may not really guide treatment, whether what molecule is going to help you more with treatment. Are you going to use the bisphosphonate? Is it going to be teriparatide? Is it going to be denosumab? So just the FRAX tool without BMD may not be as useful. Fracture risk may not be reduced by treatment just because the FRAX tool has given you, okay, there is so and so probability of you having a fracture in the next 10 years. What can you do about it? Maybe nothing. Even if with the best of the treatment in a particular scenario, a FRAX tool may not be helpful to reduce the risk of the patient. And another important thing, which is most important matter of concern, that it has not quantified different categories in a different manner. Suppose somebody has taken steroid at a lower dose for 1 year, and somebody has taken steroids at a higher dose for 10 years. Both of these will fall in the same bracket in the FRAX tool. So there is no quantitative division between the two, and the assessment may vary, the clinical picture may vary between the two people. But the FRAX tool, it may show just the one thing that, okay, both are at the equal risk. They are in the same bracket, whether it is the duration and the dose of exposure has not been quantified in this tool. So we definitely need to readjust and rethink about how should we adjust our FRAX tool. In the Indian scenario, I feel that because not many of us are using FRAX tool in our clinic, it may be important for you to just start using this tool and see how get used to the concept of, which patient is clinically more at risk of developing a fracture. And maybe once you're very confident with it, you can go into the deeper depths where you want to really quantify between and compare between the two patients. So we definitely, yes, sir.
I have a question here. I mean, do you think there's a role of QCT in calculating the FRAX score?
So again, I think so, quantitative CT, yes, sir. But it will again fill in the variable of the BMD. Just like we have the BMD, similarly QCT will fall in the same bracket. So FRAX tool essentially will also quantify how prone is your patient for repeated fall. We have some patients who have misbalance. We have some patients who are diabetics. We have some patients who have inflammatory arthritis. So some of the patients may have those kind of diseases or vulnerabilities which may not be quantified by either our BMD or quantitative CT.
Absolutely. I mean, I fully agree. I think as a prognosticator of fractures, the FRAX score is invaluable. The only problem is, it's interesting that the definition of osteoporosis has changed over the years. So when we started taking interest in osteoporosis, it was fundamentally defined as, bone density per unit volume. But that is, how osteoporosis was defined. But then today it is a deterioration in the quality of bone. So that's how osteoporosis is defined. And interestingly, that brings in a new factor, and that is not just the quantity of bone, but also the bone turnover is important, because If you have bone which is not being turned over, it's still quite dense bone, but it's fragile bone. And these patients are equally at risk of getting, repeated fractures. So that's how the definition has changed. And that's why your TBS, I think, has become so important. So I fully agree with your points that, yes, FRAX score is obviously a very important prognosticator, but I don't know, just BMD alone may not be sufficient, and maybe you need to perhaps include one or two or one or more markers of bone turnover. Do you agree with that?
Absolutely, sir. Because those bone turnover markers will help you guide your treatment. Your treatment which can change from one reading to the other based on what you have found in those turnover and how long, and your prognosis, how long it is going to take and how you go further. So I think we need to really be adjusting our FRAX tool, apply it to the Indian scenario, have thousands of patients undergone the tool assessment, and then validate your results that, okay, in the Indian scenario, this FRAX tool has given me this probability. So we need to have good follow-up and our own FRAX tool, because the FRAX tool given online is based on the European study, European data.
Exactly.
So this is a rough adjustment of how FRAX tool can be adjusted based on the prednisolone equivalent dose of steroid that the patient has taken in the past, where we can quantify.
Just like the BMD, which needs to be calibrated. Otherwise, you will get false results every time.
Absolutely, sir. So definitely there is a relevance of FRAX tool in the Indian scenario, but we need to have more Indian data. We need to have an Indian FRAX tool. And I hope that Pulse Pharma, who has taken this initiative now, is able to come up and help the clinicians with a validated FRAX tool for our country. Measures, definitely talking a little bit more about osteoporosis, we need to emphasize with our patients on increasing the physical activity, stopping smoking, restricting alcohol, and most importantly, reducing risk of fall. We all know now from the dramatic and landmark paper where it says that vitamin D, consumption of vitamin D will reduce the fall of the patient. And there is a little bit role of Tai Chi, which is picking up very widely in India now, especially in Mumbai, where people are getting more and more balance training and reducing their vulnerability to fall, which has a direct effect on the FRAX score assessment. We know that our osteoporosis medications will work in different ways. And the result of these changes is that the fracture risk should be reduced. Otherwise, what's the point? I just don't want a happy BMD or T score. I want a patient who has a lesser chance of having a fracture. So we all have our own choices, and Sir will be able to tell us more about what his choices are. So we typically oral bisphosphonate has been the long-standing gold standard, but the use has been going down in India tremendously, where a weekly tablet is given overnight fast, 200 ml water, and we know that patient needs to remain upright, and it has definite anti-resorptive actions. We do have possible side effects, and we all know about the atypical femur fractures, which have increased in our clinical practice, and we see more and more patients coming with bisphosphonate fractures. IV bisphosphonate still remains a standard of care with many people because it is not so very expensive, and the patient compliance is very easy, that it can be given once in a year for 3 years. Definitely, we need to preload our patient with a good amount of calcium and vitamin D. Infusion time should be definitely more than 15 minutes and should be given in a hospital setting. Any avoidance of major surgery, dental hygiene is another thing. And it has been clinically proven to have had the longest affecting molecule in the literature. So
just one point here, I think, these bisphosphonate fractures, they sort of, they're clearly indicative of what I was talking about, that these people on bisphosphonates, they have hard bone, but there's static bone, the bone which is not being turned over, and that is caused, brittle bones, and they tend to fracture as well. Now, typically, if you see, these papers have mostly come from Southeast Asia, Singapore and other places, and they are typically small structured people. The fracture happens in the subtrochanteric region very typically, and it's a transverse sort of fracture anatomy. So that is why I think it's important to also give bisphosphonate holidays to allow the bone to sort of turn over and get fresh bone. That's what I wanted to say. And the other thing is regarding the zoledronate, have you encountered cases of jaw necrosis?
I have no. So in my personal experience, I haven't come across as yet. But one of my practicing friends in the area, he came up, he did share about his patient who lost many teeth and had some dental procedures done. And then it was probably found that it was, but many people come with jaw pain. I don't know whether it amounts to necrosis, but jaw pain is quite common after having given the zoledronate or even oral bisphosphonate.
Yeah, particularly with zoledronate, actually, and pomidronate, which is of course not used so much now.
So calcitonin nasal spray, yes, it was a hot favorite at one point in time. Then it went down with the risk of carcinogenesis, and then it seems to have come back into practice where people are using it, especially vertebral fractures. So it has proven to be of no use when it comes to hip or non-vertebral fractures, but vertebral fractures, I think many of my spine colleagues still use a lot of calcitonin nasal spray.
I think it has a very powerful analgesic, centrally acting analgesic action, and it
Absolutely.
seems to have a beneficial effect in spinal canal stenosis. I think those are the two main areas where it is still being used.
Absolutely, sir. Teriparatide, I think as years pass by, this is becoming more and more in use, even more than zoledronate in many people's practice. We need to avoid using it in hypercalcemia. This is exactly opposite of what bisphosphonate is. That is to be avoided in hypocalcemia, whereas teriparatide is to be avoided in hypercalcemia. In severe renal impairment, it's contraindicated. In mild to moderate, you could still use it. You have to warn the patients about nausea, dizziness, and sometimes postural hypotension, especially in the initial few days. So typically we use a 20 microgram dose per day for 2 years. So do you use zoledronate or teriparatide? What do you use more so in your practice?
So I think the indications are slightly different. If the BMD is 2.5 or higher, then perhaps zoledronate is sufficient. If it is -3 or less, then you will need to use an anabolic. And the options you have today are the teriparatide and the denosumab.
Yes.
So before teriparatide, I look very carefully at the vitamin D, and I think that needs to be corrected before you start these patients on teriparatide. I also take a look at the parathormone levels, because you don't want, some of them have secondary hyperparathyroidism, and these are not suitable patients for teriparatide. So the initial workup should include that, and that needs to be corrected first, and then only you can start on teriparatide. There's a slight problem with patient compliance because they need to take the injection every day.
Yes.
But there's no doubt that it is a very good anabolic agent. The other thing is that people who have already been primed on bisphosphonates, they perhaps take a little bit longer to respond. The general consensus today is that once you start teriparatide, you need to continue this treatment for 2 years, 24 months, before you actually can stop it, or before the patient has significant clinical benefit. So I think those are the thoughts as far as teriparatide is concerned.
So yes, teriparatide is anabolic, and sometimes the patient may even have a fall in the T-score in the initial part of the treatment. So don't bother doing the scan, BMD Dexa scan anytime early. I typically do it only after 1.5 years or during the completion of the treatment.
2 years.
In the initial 1 year, definitely there is no role. We all know that intermittent PTH is what is anabolic. If you give it a continuous infusion, if we give with the help of a pump, then it is going to be catabolic. That is the reason we give a daily dose and not a continuous infusion at the hospital.
There's some evidence of osteosarcoma in rats.
Yes.
But I don't think there's been a report in human beings.
Right, sir. The last kid on the block is denosumab, and we all know about it's to be given 60 milligram, depending on what you are treating it for. But for osteoporosis, 60 milligram subcutaneous dose every 6 months. It is to be avoided in hypocalcemia. So one must do the levels before and even 2 weeks after. you can have cellulitis, a skin infection. That is one possibility, and it can be given in patients who have renal impairment. It has been observed that if there is non-compliance of patient on denosumab treatment, you can have rapid bone loss and increased fracture rates if you stop in these patients. So any experience of non-compliant denosumab fractures?
I think patient compliance is better with denosumab. The only thing is that there are few, it's not clear really when you actually stop the treatment with denosumab. And I think there are
Some companies say don't stop.
Yeah. So there are some recommendations. A few, I think 1 or 2 papers where they've switched to bisphosphonates after a course of denosumab. I think, and that's the reason is that if you do not they give some sort of support to these patients, they tend to again have a fall in bone marrow, bone mineral density.
Yes, so that is a very important point that you have made. And I think this is another take home for all our participants who are attending today, that if you are very excited about giving denosumab to your patients, please follow them up and you make sure that they are continuing with the treatment or some form of something. Otherwise, they could land up with serious fractures and reversal effects, which can happen with incomplete treatment. So for practical tips, I do refer to some guidelines, and this is a very nice paper which I would recommend to many of the people who want to have basic understanding how do you approach your osteoporosis patients. I'm not asking you to just go blindly with what they have recommended, but the approach of how they have treated osteoporosis is very intuitive. So thank you so much for this opportunity, and I pass on the task to Buddhadeb sir. Thank you, sir. Dr. Harsh, are you there?
Yes, I'm very much there. It was a very lovely talk, and somewhere I would like you to also, address maybe at the later stage about the emerging risk factors for osteoporosis, because we have been reading about homocysteines implication rather than reducing, BMD. It's breaking the collagen fibers in the.
That's right. Yes.
And also iron deficiency anemia has also been emerging as a risk factor. So before we go on to that, we would love to hear from Dr. Buddhadeb Chatterjee, that his presentation. And I'm sorry for that slip of tongue. And we are ready for you, sir. We're waiting for you.
Thank you. Yeah. So thank you very much again for the opportunity, and very, very, very lucid lecture by Dr. Saraogi. So I think what I have today is some cases which I hope will be interesting. So I'll start sharing my screen. So, okay. Can you see my screen?
Yes, sir. You can see your screen. Go ahead.
So I am basically a joint replacement surgeon. So that's what I do. And I was trained by Dr. Chittaranjan Ranawat in New York. I was very fortunate to be trained by him. And I consider him as a real doyen in the field. So, okay, so I'll just show some interesting cases, and I would like Akash to participate and come in with his views. And if there are any questions coming in from the chat box, we can take that as well. So this is the first case, 65-year-old female with pain both knees for 5 years, a progressive limp. She uses a cane or a crutch, severe bilateral lateral thrust on both knees, and severe varus and range of motion. And this is how she walked into the OPD, and fairly common scenario in our country, isn't it? Akash, what do you say?
Yes, sir. Yes, sir. Absolutely.
So any thoughts? How will you sort of...
So it starts with the patient's main complaints. What is the expectation out of our treatment? Because, I mean, there are patients coming to our clinic who say that we want to sit cross-leg and do everything. They may not have done it for 20 years. So the first thing is to know the patient expectations, a good clinical examination to understand the correctability of the varus and the ligament status of these patients, and also understanding the comorbidities of the patient, the fitness status of the patient, and do appropriate investigations, typically a radiology X-ray. And this patient would end up with a TKR, most likely. And then we think about anything else in terms of osteoporosis, something else. So this is a good knee. Okay.
Yeah, so that's the kind we get, isn't it, in India? So
Yeah, absolutely.
it's almost a relearning of the art of arthroplasty when I came back from the US.
Yes,
So
sir.
it's almost a relearning. But anyway, I think yeah, that's about covers it all. So I think what you said was a very important point is counseling. So you really need to be very practical in counseling these patients of what to expect. And of course, curious enough, you can give pretty good results here actually. And then of course comes the question of planning the surgery. So what is your preferred method? Would you like to put in an augment, or would you like to bone graft?
So depending upon the severity of the loss, I think the challenges in this case, number one would be the approach, because the knee would have hardly any, I don't know how much would be the bending in this knee joint. So even flexing this knee would be challenging. Then the medial ligament incompetency, that may be the another challenge. The amount of medial tibial bone loss. So augments, yes, but bone grafts is my bone grafts with cement and screw is what is my favorite, sir.
So this is the knee on exposure. So the leg structures are on the lateral side because of
Okay.
the extreme varus. The
Yes.
LCL gets stretched out and
Yes.
attenuated.
Absolutely. Yes.
Medial structures are contracted.
Yeah.
And what you see is an enormous uncontained tibial medial condylar defect.
Yeah.
And that will need to be addressed and corrected. And I agree with you that my preferred choice is also bone grafting, and for two reasons. The first is that it is a lot less expensive than using an augment. And secondly, it restores bone. And I think that is always desirable because you never know when you might need to revise these patients. And then if you've already put in a lot of metal and there's no bone left, then your revision becomes exceedingly difficult as you go on. So this is a picture, intraoperative picture. You can see the enormous defect. The other thing it shows is that you need a pretty extensive medial release. You really need to release all the way around to the middle and behind. The deep MCL and the sometimes even the semi-membranosus, you need to the posterior medial capsule. Today, I don't release the pes ans renus or the superficial MCL. Instead, what I do is pie crusting, which was taught to me by Dr. Ranawat.
Yes.
So I am a great practitioner of that. And I find that very, very useful. Now, this is the end result. As you can see, there's a large autograft, which is
Bone graft.
yes. And then the device also is a TC3. The reason for the TC3 here is basically to protect the lateral laxity. So these knees, because of the stretched out lateral structure, the LCL, they will always tend to open laterally. That's why you need to do a TC3. So any comments?
No, sir, I think it looks really nice. I think this is what I love about the bone graft. It just restores the entire medial tibial plateau, and suddenly you can find the knee to be more stable. And I'm sure this graft would have healed well with the main shaft.
Yeah, so I have published on this. So a lot of people were rather skeptical about the the longevity of this graft, but I've published long-term results and they take up very, very well. So there is really no problem. And this is the post-op X-ray. Any criticism? So
I think it looks good. Little bit of raised joint line. That is the only one thing that I could probably say. But I think which is fair enough in cases like this.
No, I don't think there's a significant patella paha. But the thing here, what I would do today, this was done fairly long back. What I would do today is to put in a tibial stem.
Yes.
So my threshold for a tibial stem has gone down, and I would definitely use a tibial stem today, just to protect the graft until it incorporates fully.
Yeah, that stem would serve a temporary purpose, isn't it? So once the graft is
incorporated, it does protect the graft from loading it unless and stressing it until it fully incorporates. So that's the only difference. Otherwise, of course, there are papers which also say that you don't always need to put a graft if you're using a constrained implant. But I think I would probably put a graft, put in a stem. Maybe a short stem, not a very long one. Yeah. Okay, so going on to the next case. This is 70-year-old female, advanced arthritis, both knees, limited walking with a cane. Now, interestingly, she had a sudden severe increase in the pain in one knee over 3 months. And then she's not walking since then. And we, of course, we thought of infection, but that was negative on the workup. And when we looked at it, this is what it was, the right knee. And so it's obvious what has happened, isn't it?
Yeah. So she has got a stress fracture.
Yes.
Proximal tibia.
So this is a fairly common presentation. You know, they sort of manage with a bad knee, and once they get a stress fracture, and many of them are actually severely osteoporotic, actually. So your FRAX score comes in here. So, and then they completely stop walking, and then they come to you. So, anything different you want to do?
Yeah, so my trainer in Wrightington used to call it like bag of bones of the knee joint. How we have bag of bones in the elbow joint. Similar, that there was no movement at the knee joint, and that's what has led to this fracture. So definitely doing a TKR is on the go, but we will need to stem the tibia.
Yes.
And doing a proper stem will be very important. Otherwise, it will lead to non-union and tibial implant failure. Quite common if we have not dealt it properly.
So if you do not use a stem here, it leads to a stress riser at the fracture site. And sometimes the fracture can progress and separate, and then you have another surgery at hand. So that's why it's always good to stem it. Interesting point here is that, you know, a lot of the time here in this X-ray is very obvious. You see the fracture, but a lot of the time you actually don't see the fracture on X-ray.
Yes.
And I think the clinical distinction here is paramount. The tenderness will be about a couple of inches below the knee joint line. It will not be so much on the joint line, be more tender below the knee line. And if you have elicited this clinical sign and yet you see no fracture on X-ray, these are cases which should be subjected to a bone scan.
Or MRI.
A bone scan. Yeah.
So even an MRI could show the bony edema.
Yeah, either an MRI or what I do generally is I like to put them through a radionuclide bone scan, and that clearly shows up the hot spot indicative of a fracture. And perhaps it is a good idea to even stem these, because they also may actually progress into a clear fracture once the patient starts walking on them. So yes, so this is what was done. Fracture has been stemmed, and
very interesting case.
Yeah, and they do very well actually. You know, the pain straight away disappears. You don't have to actually wait until the fracture unites. You don't have to keep them off weight bearing, but the moment you stem these, you can straight away allow them to walk, and they have no pain. So I have this also is something which I have published. I've got a fairly large number of these cases, and it's very common actually. This kind of stress fractures.
So I have a question here.
Yes.
Some of them very occasionally come with a very frank fracture and a radiolucency.
Yes.
So in those cases, are you comfortable with just the stem, or do you?
So yeah, it's a very good question you've raised. You see, This sort of fixation, it provides stability in angulation and translational stability. It theoretically does not provide stability in rotation. Now, typically, the higher the fracture, lesser is the rotational instability. The more distal the fracture, the greater is the degree of rotational instability. Now, this patient did not have rotational instability, so I just left it at this. Now, if you have a patient with a very gross fracture, which is separated, then a lot of the time, even after putting a stem into the tibia, you will still have a rotational instability. These are cases where you must use a plate, an additional plate, usually a locked plate on the medial side to provide rotational stability.
Thank you, sir.
Yeah, and sometimes you also actually might need to do an additional osteotomy, especially if there's a distal fracture and which is sort of partially united or maybe malunited. So you might actually need to do an osteotomy in these cases. Not very common, but yes, you might need to do that. So this is another the 72-year-old female, progressive knee pain deformities in 6 years. She was a limited ambulator, again lateral thrust, severe varus, and limited range of flexion. And this is the X-ray. Again, fairly commonly we see in India. This is how we managed it. It's somewhat similar to the first case which we showed. So I think we'll go through this quickly.
So the lateral ligament was incompetent when you did this?
No, here, you see, that's what I'm saying. Here, in these cases, sometimes the lateral ligament is not stretched out because the knee is subluxated. It hasn't really angulated as much. So a lot of the time you will get away without using a constraint. So an unconstrained knee, and then you don't really need to stem it, but you might need to sort of reconstruct the defect using a graft. What we have done here in this.
Right, sir.
Yeah. Okay. Yeah, this is an interesting case. So, rheumatoids. So we do a lot of these rheumatoids, and again, a lot of them, most of them are osteoporotic. This is a 65-year-old rheumatoid treated with DMRD, steroids, off drugs, and bedridden since 3 years. She's not walking at all, severe pain instability, and this is what the X-ray is like. Now, interestingly, rheumatoids follow one of two directions. Either they become very stiff, and sometimes ankylose. Now, this ankylosis may be either fibrous ankylosis or it may be a bony ankylosis. The patella sort of sticks onto the femur, and then there's no movement at all in the knee. And the other way it goes sometimes is severe instability. Now, this went in the other direction. You can see that it has perhaps a degree of a neuropathic joint. It may not be a classic neuropathic joint, but it's something like a neuropathic joint where there's a global instability, severe bone destruction in a rheumatoid, and they are not able to walk mainly because of some pain and severe instability. So your thoughts? How will you proceed on this for this?
So these are the cases where the ligament balancing is very difficult. Any amount of poly, you can keep on increasing the size of the poly, but the knee does not become stable. So at the outset, to keep everything ready, the highest level of constraint ready is going to be important in these cases. Yes. The patient usually present with inability to walk because the limb is not able to take any weight. It just buckles as compared to patient having any form of pain. And maybe limited bone cuts, do as little releases, and keep all the constraint options ready.
Exactly. What I would. So you would like to keep a hinge on the table, right?
Yes.
Yeah. So exactly, I think that's the way to go. Minimum bone cuts in order to accommodate the ligaments. This is almost you can say a great type 3 bone defect. Where you can see that it's very close to the insertion of the collateral. So there may be a complete collateral instability. So when we opened up, this is what it was like, severe bone loss. But, luckily the collateral attachments were okay. So we had the hinge, of course, but we tried initially to do 1 degree less of constraint. And this is what we ended up, with a stemming the tibia and the femur. There was a large augment used for the medial bone defect on the tibia, the TC3 constrained implant, and a fairly good alignment. And this patient walked the very next day.
So I think this looks great. I think so these are the cases where probably bone grafts don't seem to be available or work as much, don't they, in rheumatoid with very severe bone loss? Yeah. We have to use the augments.
Yes, here the bone cuts are very minimal. You see, just you're just shaving off the bone, and the bone is of such poor quality that you really cannot use them as grafts. So here there was really no choice but to use an augment. And the patella, interesting. The textbooks say that in rheumatoids you should try and resurface the patella, but I find that in rheumatoids the patella is so osteoporotic that they just sort of melt under the saw, and I'm afraid that the patella might actually just come off. Fix very well. Here the patella was just a very thin sliver of bone, so I just left it just like it was. And she did well actually. In fact, this was a bilateral case, so both were. So yeah, she was walking.
This looks great, sir.
Do let me know when I run out of time so I can just stop.
No, sir, I could go on, sir.
Yeah, no, Doctor, what I know, but
you can take some more time, sir. It's very interesting. So, yes, please go ahead.
So that then that'll be the last case. So, so this is another, pain and increasing deformity. Since 1 year, there was no relief with a brace. This patient just. This was, of course, the knee was done in '94, and this presentation was, I think, it was about almost 15 or 20 years post-operative, and this is what the patient came with. Yeah, Akash?
Yes, sir. So infection workup was negative. So we are thinking in terms of poly wear with aseptic loosening, and then landing up with lateral laxity and instability. So single stage revision with constrained option. I think this was a CR knee, wasn't it?
This was a CR knee and the LCS, which has a round on flat design, and there is a slight problem of wear. So here, obviously, there is quite severe medial wear, as you can see. Maybe the knee was balanced adequately. I don't know. That is just something. I don't have the previous X-rays. So there is obviously quite significant poly wear on the medial side and instability on the lateral side. And obviously, this. So we decided to change it to a PS design, and this is the post-operative X-ray. Again a TC3 PS with stems on both sides, and she did well after this.
Looks great, sir. So were you able to clinically correct the varus pre-op?
Yes. We needed to do some release on the medial side, but otherwise it was all right. We didn't really plan for a hinge there. So here again, worsening pain and instability after about 15 years after a TKR, and she was a long-standing rheumatoid osteoporotic lady, and this is the X-ray.
Oh. This all poly has.
Yes, first of all, I think an all poly is contraindicated in a rheumatoid.
Absolutely.
Never do that. So, but still, this knee lasted a while, even so. And
infection workup is negative, sir?
Infection workup was negative. So this was the other case where it just sort of. This is obviously loosening with a lot of osteolysis, mainly on the tibial side. The femur was also loose, by the way. So yes.
I think there will be absolutely no metaphyseal bone available for fixation.
Mm.
Okay, so I would use a long stem for the tibia. Taking out that cement from the tibia is important because you may just keep on going off track and not go into the canal. So that is one important thing. And I'm not sure why the femur was so loose in this particular case.
Well, not completely.
Infection.
I think it was a put in flexion actually, the femur. The implant was in a bit of flexion.
Oversized.
And yeah, no, because it was flexed, so it's appearing to be oversized. So maybe that had an issue with the balance. So the two things, I think you can either go in with a sleeve in this.
Yeah, sleeve and stem both.
Yeah, either sleeve and stem, or you can go in with a large triangular wedge, which also can take care of the medial tibial defect. So, which is
but not very confident even with the lateral part of the tibia, sir.
Yeah.
So probably I would have chosen a sleeve and a stem.
Yes, so sleeve is a good idea here, no doubt. But this is what we did, and use a large augment, a wedge-shaped augment with a constrained device, and we used a cemented stem because the bone was quite osteoporotic. So we really we thought we wouldn't get a hold with a non-cemented stem, with a fluted stem. So we used the short, thick cemented stem. And
when just two things I wanted to ask, sir. So
yeah.
Despite the wedge, we did have to use some cement to build up more, isn't it?
Yes,
on the medial side.
It was. We had to cement it actually.
And on the lateral side, in the retrospect, would you consider bone grafting and then cementing for that lateral cutout part of the tibia, proximal tibia?
Was okay. The lateral side was all right. The insert was only about 12.5. So we really didn't need to go for a very thick insert.
No, I meant in terms of bone grafting, the defect, the metaphyseal defect internally that it has created, where on the tibia where the stem had actually come out from.
Well, you can, but if you have got a good fixation distally, in the, you see, this is already, almost a 3-zone fixation.
Right.
So yeah, so I think probably, and once the bone gets loaded, by Wolff's law, it will tend to throw up new bone. So,
okay.
So this is again in our revision. This is another case which had a 3-year-old TKR, had a fall and was not able to walk, severe pain and swelling, infection workup negative. And so, your thoughts here?
Okay, so there is a fracture.
Yeah, supracondylar periprosthetic fracture.
Very little bone stock. Yeah.
Yes.
Not sure. Definitely not nailable. It's a PS component, and the component, this is too short. Osteosynthesis, I'm not sure whether it will give immense purchase. Medial plate. Did we do a CT scan, sir? Mass CT or something to know whether?
I did not actually. You see, the thing here is that if the implant is loose and comes off easily, then it's okay. But revising these is very difficult because
so the entire distal chunk will come out with that component.
Yes. So yeah, so then you really will you need to sort of replace it with a tumor.
DFR, distal femur replacement. So I would take my chance on fixing this. A good plate.
Yeah, with a lateral.
Maybe even dual plate, but definitely middle plate. And
so this is the fixation, and it worked out well, and it actually united down the line. So maybe I was lucky, but most of these cases you will be able to fix the distal, unless it is fractured.
Use a stem from the central box, sir.
Yes, yes.
Okay. That is the internal as well as external fixation.
Internal as well as external. So sometimes these cases you will get away with a fixation unless it is a very low fracture where it is just fractured above the box. There it's extremely difficult to fix it.
So even if one cortex is there for you to hold upon your screws, I think it may work.
Yes.
Like in this case, you had the medial cortex available, so you could put on the screws.
Yes, yes, exactly, exactly. So this is another 60-year-old male who had a TKR 7 years ago and had a fall treated with internal fixation. X-rays revealed a non-union. He was treated with internal fixation, but had a non-union knee flexion at was reduced, infection workup negative. So this was the picture when he came. So you can see a clear-cut non-union of the femur. So again,
I think the shaft is lateralized significantly to the plate.
yes, probably reduction probably not adequate, which is why it didn't unite.
Refix, but the component was the component loose, sir.
Yeah, so the component
looks loose. The anterior cortex of the femur, you can see the
tibia was completely loose actually.
Yeah.
Tibia was loose, so that's why we
revision with as much bone as you can preserve.
Yeah. So we decided to revise both on the tibia. Tibia needed revision anyway. It was a difficult exposure, so we had to do a TTO. And then it's the tuberosity back with a staple.
Yeah.
And, use the sleeve here on the tibial side, and on the femoral side, put in a this is a hinge actually. So we put in a hinge here.
So would you consider plate augmentation with this or no?
It was very secure actually, just with one wire. We got a very secure, and because it was a hinge, so that itself was working like a splint.
Correct.
So yeah, so we decided not. And the problem is, if you use a hinge and a sleeve and all that,
no space for
it's almost impossible to put in a plate because we have hardly any bone to put the screws in.
I agree, sir.
So that's why we decided not to, and it united, with time. So this is, I think this is the last case. 72-year-old had a fall because of Parkinsonian patient. They are very prone to falls. They were not able to, stand after that, but came with a fracture but refused surgery. So this was the initial X-ray, and obviously needed surgery, but he refused. And after 6 weeks, we put a brace. That's the best we could do. The X-ray showed increasing deformity, and then 6 weeks or 8 weeks later, he came with this. Now what?
So this is the patient in which the extensor mechanism may not be really intact. Quadriceps may not be functioning. It may be ruptured. The patellar tendon seems okay, but you don't know what is the status of the extensor mechanism.
No, extensor mechanism was okay. He was generally weak because of Parkinsonism, and he had a lot of gait issues. But extensor mechanism as such was okay. But the problem is that this was, now a 2-month-old fracture.
Yeah.
And it had not.
I don't think osteosynthesis is a good option.
Yeah.
And I'm not sure whether there will be any bone left to salvage.
Yes.
You have removed the component.
The
so
distal fragment was
replacement ready for this case.
The distal fragment was very, very tenuous.
Yeah.
So eventually there wasn't really much of an option except to do this sort of replacement. Yeah. The distal femoral replacement.
So did he have an extension lag clinically?
Post-operatively, I must say he did quite well. I mean, we told him not to walk without support. So we gave him, we told him that you really must use a sort of a tripod stick to walk, which at least till the end of follow-up he was doing. So I hope he has not given it up.
Just my general observation has been, sir, that especially with Parkinsonism, these patients are quite free with pain. So pain relief is one of the most important indication why we operate on these patients. Yeah. But in terms of mobility, they always walk with their knee flexed. I have never seen them completely extending their knee joints.
Yes, true. That is, they have muscles are weak and muscles are hypertonic. So they sometimes have a sort of a flexed attitude at the knee because of tonicity. So they tend to walk, and that's why it's all the more important that they should use, if required, they should use even a walker maybe.
Yes.
But yeah, but because it's very difficult to keep on operating on them if they come back to you with repeated fractures. So I think that's the lot. I have some hip cases, but I think perhaps it's time to call it a day maybe. And I thank you for your patient hearing and for participating, and my sincere thanks to the organizers for this very interesting session.
Thank you, sir, for those amazing cases, sir. Thank you.
So yeah, stop sharing.
Thank you so much, sir, for sharing those cases. And to begin with, I would like to inform you we have an audience of about almost 1,975 people who have been listening to you and viewing to those cases and your sharing of thoughts. And I'm also very grateful to Dr. Bijlani and the OrthoTV for allowing us an extended one. But before we close the program, there are a few things which occurred to me, especially since the last week's presentation by Dr. Sunil Parwa. Now, he says that typically we are more indulgent in post-menopausal osteoporosis, and we tend to debate more about that, and we see women experiencing having more osteoporosis and probably experiencing more fractures abroad. But when we look at the Indian scenario, it's radically different. What he was indicating was there are more men who have osteoporosis, and also they are more likely, in the Indian context, they're more likely to be experiencing a fracture. Any thoughts on that, sir?
I'm not sure whether more men are osteoporotic in India. This is, I must say, is new information to me.
Yeah.
More men may be osteoporotic when you compare with the West, but in absolute numbers, I still think women are more osteoporotic in India. I think, the contributory factors here are, number one is our small skeletal size. You see, as a race, we have a smaller skeletal size. And it's well known that bone depletion occurs more if your skeleton is small rather than when it's a large skeleton, as in the Caucasian races. So that's one. Even genetically, we are more excuse me. We are more susceptible to osteoporosis than compared to the Caucasians, and particularly to Negroid races who seem to be immune to osteoporosis. This is also well documented that Negroid races or African races are susceptible, are resistant to osteoporosis, whereas we are. So it is, I think, genetically determined. There's something to do with that. So,
Dr. Saraogi, your thoughts on that?
I think so. Definitely women more than men, and about 3 times more than men. That is what is even the Indian statistics are, that 3 times more women are osteoporotic as compared to men. As compared to Western men, maybe Indian men are more osteoporotic. I don't know if that could be true actually, but in comparison to the other gender, definitely not.
To put it lightly, because I remember distinctly commenting that probably men have more vices. Right? That's the reason which takes us closer to the osteoporosis. Because if you look at the FRAX tool as well, so bringing in overconsumption or higher consumption of liquids, and then smoking, and yes, nutrition has been, and most of the issues are to begin with related to the nutrition.
I would say that Western men smoke much more than Indian men.
But the structures are bigger, as Dr. Chatterjee pointed out.
I agree on that.
Yeah, that is one of the points. Yes, because our smaller structure, if I can say that, leads us to many issues, osteoporosis, and the CVD also.
Yes.
So somewhere I was also thinking, since I have spoken about CVD, of late there has been a debate about the role of homocysteine and more of hyperhomocystinemia in advent, and it has implications in osteoporosis. Your thoughts first, Dr. Saraogi, and then I'll go to Dr. Chatterjee.
So homocysteine became a very hot topic of discussion by the year 2010, where high homocysteine was directly correlated with increased mortality and cardiac incidences. And that's when we started checking homocysteine levels for population and starting then on B12 and folic acid. Lately, we do have literature to suggest that there is a correlation, indirect correlation between homocysteine levels and having osteoporosis. I think the physiology is more so the same, where it affects the bone turnover and causing osteoporosis. But it will be still more important for the cardiac part of it. And if the homocysteine levels are high, whether you do it for osteoporosis or not, you're definitely going to correct them or treat them from a cardiac point of view first, as compared to bones.
Dr. Chatterjee, sir, especially I'm looking in the terms that, as I understand what I have read from the literature, you may not have a reduced BMD to begin with, so it becomes a greater risk factor and more something to be afraid of, because it's acting at the cross-linking and other things. So your comments in that context also, sir.
Yeah, I mean, it would appear to be so. But personally, I mean, I think one should aim to take corrective measures. There are papers to sort of indicate, which are indicative of that. But personally, I really don't have any experience to say whether this is specifically the case. I mean, it may be one of the many factors.
So one quick comment, sir, that any increase in level of homocysteine is an oxidative stress to the body. Now that oxidative stress is to the cardiac stuff as well as to your osteoblasts, as well as to all the tissues of the body. So if it is an oxidative stress, it creates an environment around your cells which will cause all those effects. So I think that is how it is causing more increased risk of fracture, osteoporotic fracture.
There has been, sir, growing school, though it's very gradually growing, that they are also, when they're checking for, 25-hydroxy and the PTH and other things, which when they are taking into consideration, they also insist on, a measurement of homocysteine levels also. And they tend to correct that and include that in part of therapy. Another aspect which has been coming on is the role of iron deficiency anemia, which is maybe we don't have that much higher noise, but then looking at nutritional issues, so there is an implication there also for iron deficiency anemia and osteoporosis.
I think anemia is a pointer towards nutritional deficiencies. So whether anemia has a direct bearing on osteoporosis, I don't know, but it's probably a window, or it's an indicator that there are serious nutritional deficiencies at work. So you need to correct all of them. I think probably also a pointer to get a more detailed workup done.
So, I mean, Harsh sir, we know that smokers have higher incidence of lung cancer, but we also know that those who smoke are also more prone to, alcohol also goes hand in hand. And one could say that alcoholics are at higher incidence of lung cancer, where there is no direct correlation between the two. So it is not causation. I don't think iron deficiency anemia itself would be causing osteoporosis. In the literature, definitely it has not been proven till date, but it may be associated, because iron deficiency anemia, especially in India, is mainly in females, and females in general are at more risk of osteoporosis. So automatically IDA, iron deficiency anemia, is more associated with osteoporosis, but I don't think it is causative for osteoporosis.
Okay. It's not a very direct role as of now. Maybe there's some scope to do, quite a bit of work there. That is what I understand.
Iron overload is definitely a cause of osteoporosis. That has been proven. We have literature for that. Iron overload causing osteoporotic fracture.
Yes. Yeah. Coming to maybe one of the last one or two questions. What I want to understand is, since we are at osteoporosis and it was envisaged as discussion also on FRAX tool, the relevance of FRAX tool to the masses, though you have touched on it briefly, especially in the Indian scenario, because affordability of Dexa and the availability of Dexa across, especially when we are looking at the interiors. And second is, last time I had Dr. Kiran Acharya on the program, and is doing some work on trying to validate or see of FRAX with or without Dexa. Works. Any thoughts on that?
I think we all should be using the FRAX tool, whether in your area you have BMD Dexa or not. You must use the FRAX tool. Suppose you are in an area where you don't have BMD Dexa, you use the FRAX tool and identify those patients who definitely need a Dexa scan, and then maybe scale them and send them to a place where they can get a Dexa done. So that is one utility of FRAX tool where you don't have Dexa scan. In areas where you have Dexa scan, probably the FRAX tool will give you more accurate estimation of what is the estimation of fracture and the clinical relevance in your practice. So I take it that whether you have BMD Dexa, you don't have it, you still got to use the FRAX tool.
And do we need a Indianized version? Last time, I think Dr. Marwa only made a comment that Dr. Jha is working and trying to evolve. But I do understand there is an existing version, but which is not.
If you ask the orthopedic surgeon in the clinic to sit down and jot down those questionnaire and answers to them and calculate it with their calculator, nobody is going to do it, sir. It has to be automatic. It has to be either on an app or a website. It has to be done by someone who is not a doctor, who is probably a staff nurse, who is a receptionist, who is trained to do that, and you have it automatically. So I think doctor compliance, we always talk about patient compliance, but I think doctor compliance is a key issue with the FRAX tool. We need to have something simple, quick, which does not take more than a minute. So if you go for a very ideal FRAX tool, which has got 20 questions, trust me, everybody will clap for it, but nobody will use it.
Nobody will use it.
So we need something which is very quick, which can be done by the receptionist, which takes less than 1 minute, which is online, which does not involve a lot of paperwork, which has not more than 10 questions, which is less than 10 questions, and gives immediate result. On the FRAX tool itself, you can see the BMI just by putting the height weight. On FRAX tool itself, everything gets updated quickly, and you get a result in less than 60 seconds. So that is the reason that till you don't have something like that as the Indian version, it is all right if you're using the Sheffield version, which is available online for free.
Dr. Chatterjee, sir, your thoughts?
No, I think he very nicely and very succinctly put. So, busy OPD, it is impossible to sit and do all these calculations. It has to be, it's just like you calculate GFR, you do it straight away on the mobile, isn't it? You have got a nephro patient and you have to do a TKR or something. You know the GFR because that will determine all your drug doses. So something similar has to be there for this.
One last question which comes to my mind, first to Dr. Saraogi. We have been moving away from bisphosphonates, and part of it was indicated by Dr. Chatterjee also. And we see progressively now, thoughts being more focused on anabolic drugs, yes, teriparatide, and then we are talking about denosumab and the IV, the bisphosphonates. Though Dr. Chatterjee did bring about the atypical fractures with the bisphosphonates that have been happening. So, but what I realize is progressively there is a shift from the oral medicine to the injectable therapies. That is what I gather from your talk, Dr. Saraogi. And also when we are talking about anabolic agents and their usage, a need for rapidly building up the vitamin D levels. The patients need to be replete with the vitamin D levels. That is what I gather, and I want to comment on that as well from you. So what kind of a dosage, what kind of things you are looking at when you are suggesting these things?
Yeah, I think the last question is the most controversial of all. So yes, Dr. Chatterjee told it very nicely while we discussed this, that before you start any of these treatment, please replenish your patient's vitamin D levels, calcium levels, get those blood tested before you start teriparatide. Know what your alkaline phosphatase or your parathyroid levels are. So I mean, the most important bit is have a standard practice. Don't just keep changing from one to the other to the third one just based on whatever the market dynamics are. I don't think bisphosphonates are gonna go away. That's what is my now personal opinion. What I would say, I do not have any scientific basis for that, but I think that bisphosphonates have stood the test of time. I don't particularly like oral bisphosphonates because sometimes patients are lost to follow up and they just keep on continuing taking those for years altogether, landing up with a bisphosphonate fracture. Injectable bisphosphonates is a more controlled environment for me. It is once in a year and it is only 3 doses and very, very cheap. Why people get complications is a different story, because they may not have replenished the D levels and calcium levels. Patient may have gone into sudden hypocalcemia. They may not have infused it in a hospital setting. They may have infused it in a very fast manner. Patients may not have been counseled about the fever, about the body ache. So there's a lot of effort involved on the part of the orthopedic surgeon when they are administering an injectable bisphosphonate. Having said that, the effects are quite long. If you give appropriate bisphosphonate holiday, then the side effects are minimal or negligible. So teriparatide is like a easier way out. You can just replenish those levels and do the blood test and just give it, and then it is done. So, and it is good for severe form of osteoporosis. Denosumab, I'm still not completely confident as a lone therapy. Definitely there are concerns about patient missing dose and fractures, and there are more and more every week you will find one new article coming up with a denosumab fracture, whether patient had incomplete treatment or completed treatment and was not switched over to something else. So which you mean for sure that just on denosumab, you're not going to base your osteoporosis practice. You will need something along with it.
Does it mean we are trying to usher in a paradigm change in the treatment? So yes, the combination treatment is going to be the norm in the coming years? Or Chatterjee, please?
No, see, I think it's wrong to say that bisphosphonates are on the way out. I still think they are the mainstay of treatment. You see, basically there are two classes of bisphosphonate. The first group is the alendronate and the zoledronate. The other group is the ibandronate and the risedronate. Now, the problem with ibandronate and risedronate is they have very good spinal action, but they don't seem to affect the appendicular skeleton as much. Whereas the first group of zoledronate and alendronate, they affect both the appendicular and the axial skeleton. So they are in a better class of drugs. Definitely, the advantage of zoledronate is that it's once a year dose. And especially if you're treating, a patient of neck femur fracture or a trochanteric fracture, you have a captive audience. There were some misgivings initially that if you have fixed the fracture and you give zoledronate, that sort of retards bone healing. But that has been now dispensed with. Then they've demonstrated that there is no alteration in bone healing. So you have a captive patient. Before going home, you can give the first dose of zoledronate. So I think that's a definite advantage. And you can call these patients back after 1 year for the second dose and give the third dose as well. Like I said, I mean, you need to really have a guideline. The NICE guidelines are also there. I mean, if you can follow the guidelines that that a particular BMD, you would go for a bisphosphonate. If it is below a certain level, you would like to use an anabolic drug. So I do think bisphosphonates still have a role. It's just that, after a certain time, you need to give a drug holiday to allow the bone to sort of replenish and not become static. that's what is leading to these fractures. So, yes, I think that's what I would say.
Thank you so much, sir. And thank you so much, Dr. Saraogi. That brings us to an end of this program. To sum up it in one line or one statement, I would like to, what I take home message is, yes, the FRAX is relevant to the Indian scenario, and it continues to be relevant. And more so because it can be used in interiors and other places, even PHCs is where it can be used for the thing. And the drawback continues to be, yes, it gives you always a risk for the next, over the next 10 years. Fracture risk over the next 10 years. We cannot use it for evaluating the progress which we can make with the treatment. That is what I understand. Correct me if I'm wrong.
Absolutely true, yes.
That is the take-home message, and we thank you so much, and Dr. Chatterjee, for sharing 10 cases which nobody has done till now, and a very interactive session, which is truly a tete-a-tete, as the name goes by. So with these words, I thank you both for bringing in your experiencing, and I'm sure 1,000 people who have been there with us during this program, they are immensely benefited. And also my thanks to Dr. Bijlani, OrthoTV, for helping us and allowing us to extend the program. He said, it's going on pretty well, don't worry, we have time. So we are not going to be stopping anywhere till the presenters, they decide to stop. So with these words, I sign it off here. Thank you so very much for being a part of this program. Thanks a lot.
Thank you.
Thank you. Thank you. Thank you.
Have a great weekend.
So do you, sir. Thank you so much.
Thank you.